All right, well, why don't we start? Thanks so much for joining us today for what should be a fantastic session. Scott Podolsky. I helped to organize our departmental seminar series. As many of you know, since 2011, our department has featured programs in global health and social change as an organizational framework designed to promote research and education, both within DGHSM and across HMS affiliates. And our program in global public policy and social change has been particularly productive, not surprisingly, under the leadership of its director, Dr. Vanessa Kerry, and its research director, Dr. Margaret Bourdeaux. As we'll hear, their team, with a focus on connecting practice to policy, has likewise focused on building equitable access, delivery, and security in healthcare at the patient and population levels. To do this, in both domestic and international settings, they've conducted research, convened and facilitated multi-sector, cross-disciplinary policy discussions, and provided training and education to practitioners and policymakers alike about health systems, equity, and delivery. We'll get to hear directly from Dr. Kerry and Dr. Bourdeaux regarding their efforts to promote coalitions and collaborations both within and beyond Harvard in order to engage with present, emerging, and future health concerns. Dr. Kerry received her undergraduate BS with honors from Yale with a major in molecular, cellular, and developmental biology. Her MD from Harvard, where she graduated likewise with honors, and a master's degree in health policy, planning, and financing from the London School of Economics and the London School of Hygiene and Tropical Medicine as a Fulbright Scholar. She thereafter completed her internal medicine residency and critical care fellowships at MGH, where she serves as a critical care physician and as the associate director of its Center for Global Health. Among other remarkable accomplishments, she's the founder and CEO of Seed Global Health, a nonprofit that partners with the public sector to invest in health strengthening by training needed health professionals in resource-limited settings. Dr. Bourdeaux received her undergraduate BA from Harvard and her MD from Yale, the reverse of Dr. Kerry, and completed her residency in internal medicine and pediatrics at the Brigham, while completing her MPH at the Harvard T.H. Chan School of Public Health. She was one of the first graduates of the Global Women's Fellowship at the Brigham, and she would subsequently work with the Office of the Secretary of Defense to analyze the U.S. Department of Defense's global health projects and programs, and lead a joint Harvard-NATO team of analysts to evaluate the impacts, challenges, and opportunities international security forces have in protecting and rebuilding health systems in conflict with the states. She is likewise a faculty associate of Harvard's Berkman Klein Center for the Internet and Society. Dr. Kerry and Dr. Bourdeaux will today discuss advancing health equity through evidence-driven policy, and then we'll have time for questions and discussion, and you can submit your questions anytime through the Q&A function. With that, I'll hand over to Dr. Kerry.
Thank you very much for the introduction. Hopefully everybody can hear me. And thanks for joining today. I'm very excited to share some of our work and to be able to tell you a little bit of what we've been up to together. And Margaret and I represent actually a team that has been working on this for a while, and one of our colleagues, Amory Sazdi, has been very involved as well in helping us. And we've had a collection of students and postdocs and others who've been working alongside us, and of course, all of our partners, because at the end of the day, what we're really trying to do is to help guide sound, enduring policies in a way that is actually informed by the complexity of what truly happens in trying to deliver equitable healthcare on the ground to those that are most vulnerable. So with that, I actually want to start with something Paul wrote back in 2011, which I think very much informed this original vision for the program in global public policy and the many discussions that Paul and I had together and with many of you, which is, during my first years in Haiti, I thought of accompaniment as an idea most applicable in medical care, doing whatever it takes to cure the sick. Yet I realized that if my role as a doctor was to really cure them, then I had to step outside the traditional confines of my profession and address the conditions in which patients lived. I think we all know that what those broader conditions are can be the social determinants of health, but it also, and there's a range of things, the economic, colonialism, history, politics, but the policies, the political divides we face, the decisions we make in other sectors can inform the vulnerability of our own health every day, all the time. And if we don't embrace that intersection of how policy, politics, and sort of policymakers are making decisions, then our ideas don't necessarily get to go to scale. And they don't get institutionalized is probably the wrong word. I don't love that sense of the word, but in the sense that they endure, right? And they're durable and they can be built out and sort of embedded. And that ultimately what is really important is that policy needs to reflect the actual individuals at risk. So too often we see policies that are born out of a single group, but not necessarily the most vulnerable, or we see policies that are not truly informed by the vulnerable populations or by those that we are really working every day to deliver healthcare to. How do we ensure that that whole system is actually working in favor and in direction of those individuals? So the mission of this program is really through research, teaching, praxis, and convening. We really aim to understand, inform, and improve health and social policies, both locally and proximally, and globally, that can impact health, equity, and our overall well-being. We aim to really tackle what we consider sort of the most critical challenges in some ways of advancing global health equity and security and healthcare quality, as we've seen throughout, for example, the COVID pandemic and the way vaccines were getting distributed. We do this by trying to build a sort of iterative feedback loop that starts by engaging practitioners of all sorts, all of you, practitioners who are actually delivering healthcare, public health practitioners, it might be social workers, it might be families that are caregivers that are seeing a vulnerable pattern in their community, and patients in the process of policy formulation, implementation, and assessment. We aim to do policy research and analysis of policies that do exist or the opportunities for creating policy by looking at the problems and bringing together, probably most importantly, one of the things that we do that we're draw a lot of energy from and also want to bang our head against the wall from is that we engage a wide array of policymakers, practitioners, and patients, but unlikely allies, right? And we'll tell the stories today, both domestically and internationally, of some examples of our work where we've brought together these unlikely allies, if it is private sector, government, pharma, patients, to solve how do we create medical countermeasures, to be available, or if it is thinking through how do you train healthcare workforce that no one has wanted to do for 40 years, and how do we rise to that sort of urgency? How do we bring people together to find shared values, shared understanding of a problem, and to bring together deep experience and differences in sort of priorities to come together to find a solution that can be enduring and in service. And then we also hope to teach and train the next generation of leaders in these policy domains, because I think one of the things we've all seen is that we as practitioners in public health, in medical delivery, in all the work that we do, we feel and see very directly what these impacts can be, but we don't necessarily know how to communicate it in the right way, in a way that can ensure that we're actually advocating for our patients at every level and what those healthcare vulnerabilities are. And so being able to engage a rising generation and how to engage in that, in stepping outside the bounds of our traditional profession to solve those big problems in that vision that was outlined. If we can do that, we can really start to make sure that health is a leading part of any policy discussion, a leading part of how decisions and funding is made, a leading part of thinking through how do we solve today's sort of emergent problems, because we're prioritizing health, education, social well-being, the things that we need to be able to not just survive, but to thrive. So with that, we're very excited to share with you some of the portfolios of the work that we have been doing. And, I think it's worth noting that as we work across the different silos of Harvard and the different pieces of Harvard, be it MGH and the Center for Global Health, in my role at Seed Global Health, or my role here at the Program of Global Public Policy, and Margaret, who's been working at the Kennedy School, as well as here, and the Brigham, all of these things are all coming together into a common mission that all very much fit in this academic frame. So the work that we talk about is really all about advancing this academic education, research, and service and healthcare delivery praxis together. And they all come together under this rubric. So Margaret, I will hand it to you.
Well, I'm going to have to, as usual, start off with an apology because it was I who put in the word institutionalization into your slide, Vanessa. As I was looking through it, you had put ingrained, and I thought, oh, and it was misspelled. I thought, oh no, she must have meant institutional. So
All good. I looked at that word and I was like, I did not put that there.
you can't turn your back on me for 1 minute. So indeed, as Vanessa has such a lovely way laid out, the sort of mission and vision of the program in global public policy. And here is sort of our current portfolios of work. I'm going to take you through an example of one of our portfolios just to illustrate a model that we have developed. As Vanessa was saying, we try to, this is an academic enterprise, and we really do try to weave in service, research, education in everything that we do. And so we've developed a bit of a model for how we undertake the work that we call practice to policy and back again. And I'm going to kind of take you through how that works with respect to this portfolio on the left, our portfolio of work that pertains to US public health system reform and how we can build a more equitable and effective public health crisis response system. Now, this admittedly is a domestically focused portfolio of work that has grown out of the COVID crisis. But I think, and then Vanessa will pivot to some of our global work here on the right. But I wanted to focus in on this example because I think it lends itself most to describing our model. And also it will speak to this specific audience because many of you are protagonists in the story that I'll tell. So you are forewarned. Can you advance it, Vanessa? Yeah. All right, so the model is, kind of mapped out here. We start on the left side here with by working closely with practitioners who come to us with a policy problem or with a problem that they've noted in the course of providing care to patients that has to do with health equity. Maybe they're observing a profound health inequity or disparity in the course of their work, and they want to think about new approaches. They also want to think about the policies that need to be changed or systems that need to be reformed or reconstructed so that that health inequality can be addressed. Now, when I say practitioners, we use that word very broadly. Of course, it means sort of all of you, perhaps, who are directly providing care to patients in a medical or clinical sense. It can also mean other members of our community, people in frontline public health centers. We'll focus on that today. It can also mean folks who are doing bench research, trying to develop, let's say, a new medication, a new medical countermeasure, a vaccine, and they are very concerned that they are not going to be able to, the fruits of that work are not going to be able to be enjoyed by everybody who should receive it. So we work with practitioners to identify a problem. Where we come in is we collect evidence of all kinds about the nature of the policy and systemic drivers of the inequity. And we do a lot of different types of research. We may do historical analyses, case study analyses, outcome research, a lot of interviewing and discussion with stakeholders, as Vanessa was alluding to. We try to get our arms around what really are the policy drivers of the situation. And then we have a pretty unique approach to generating solutions and ways forward, which is we really do this with using what I like to call an adaptive leadership approach, which is we really generate solutions in community. We reach out to other stakeholders, other folks in other disciplines, patients, folks who are experiencing the problem firsthand, and facilitate learning collaboratives, discussions, workshops, quiet conversations, conferences, to be able to generate and think about what are some of the ways we would overcome a policy challenge or come up and articulate a new set of policies. And then that's not enough. then the fourth step is incredibly important, which is you might have a great idea for a new program or a new policy, but really how does that get implemented? And that's really where I think, I've done a lot of learning my own self in this, but you need to identify what are the ongoing programs that could be tweaked or changed, and the moving legislation that could institute some of the reforms that you're proposing, and engage with decision makers, educate them about why you think your ideas could or should be included and how they could be included in legislation. So that all sounds, horribly boring. Go ahead and turn the slide, Vanessa. So I'm going to put some color into this, and I will tell you by the end, I hope that you will agree that this is some of the most exciting work you could possibly undertake, because there is definitely never a dull moment, however dull that prior slide may have looked. So here we have
dull, it's process and it's magic when it works.
Exactly. So here we have our protagonist in our example here is Dr. KJ Seung, who agreed to serve as the protagonist in this story. Gratefully, I'm hoping that he's joined us. But KJ is a member of our department. In fact, he was my first office mate when I started working in the department. And as maybe many of you know, KJ during the COVID crisis served as the head of policy and strategy for Partners in Health's Massachusetts contact tracing program. So maybe some of you are familiar. When COVID hit Massachusetts, the state stood up what was called the Contact Tracing Collaborative. They brought in Partners in Health to train and manage the contact tracing program. And at the time, Partners in Health contracted with us, with PGPP, to serve as analysts, policy analysts and researchers, really sort of on call to address any state policy challenges that PIH faced as it was standing up this contact tracing collaborative. So we're sort of joined at the hip with KJ as he and his team went forward in designing the contact tracing program. All right, so advance one more time. So the origins of that program, how they thought they would structure it and did structure it, is sort of according to this graphic here. So they thought, okay, as people are identified as infected, their case will be reported by their, let's say, care provider in the clinical setting to the State Department of Health. The State Department of Health and this wonderful sort of computer cloud thing will then pop out a name. It will go to a case investigator. That's that little figure with the suitcase. And that case investigator will go to the infected individual, will interview them and figure out who the people are that they've exposed, all those little figures there in sort of blue-gray. And then all those people, those contacts that have been exposed, will be contacted by a contact tracer, will be told they have been exposed and they need to quarantine for 2 weeks. Some of those individuals, were early to recognize would not be able to just quarantine for 2 weeks. They would need social supports, and many of them may need medical care if they had gone ahead and developed the disease or had other medical needs. So those were turned over to the care resource coordinator who would provide those wraparound services. So this was the model and it was instituted. KJ, however, and his team were really not satisfied with it. So sort of I would say even a couple weeks in to it being fully stood up and running, KJ and the team, of course, realized that this way of contact tracing, they were getting overrun. Just the cases were skyrocketing. They couldn't keep up. They couldn't contact everybody who had been exposed. But of course, the shining, the best part about it, right, was they were really doing a great job on the care resource coordination side. Once they did reach people who were socially vulnerable or medically vulnerable, they did a great job of providing them with services. However, it was the upstream problem. They couldn't run fast enough to be able to find all the cases and contact all of their contacts. And this was, as we, probably very painfully remember, devastating to many communities in Massachusetts, particularly minority, low income communities, immigrant communities, were just suffering tremendously and continue to suffer throughout the country. And so KJ, really sat down and asked himself, was there a better way forward? Go advance one more time, Vanessa. And so, if you know KJ, truly a person who is just, well, I would categorize as a genius, and I don't say that often. And he really reached out really around the world to try to see if there was another way, another way that we could structure the contact tracing program so that it would reach more people and could address this, egregious and overwhelming health disparities that we were seeing play out. Could it not protect more people? And very soon he did reach out to a number of folks leading responses in other countries, and namely a Dr. Oshitani, who has become quite famous around the world, who was running Japan's COVID response. And Dr. Oshitani, and very politely, said, you're doing it wrong, man. The problem here is that you are not taking advantage of COVID's Achilles heel. COVID is a very difficult disease to try to stop transmission of, but it does have one weakness, okay? And its one vulnerability is that it spreads in clusters. Only 10% of cases give rise to 80, even 90% of infections. Okay, well, great. So what, right? It's like, so what that means is you have to focus on where and when and how those super spreading events, where are those clusters starting? That if you focus on clusters, rather than running out and trying to count every person who's been infected and everybody they've exposed, focusing in on the conditions in which transmission is occurring is the key to addressing COVID. And so the Ministry of Health in Japan put out this lovely graphic where they called it retrospective contact tracing. Others call it outbreak investigation or cluster investigation, where they said, instead of focusing on who has been exposed by the individual in front of you, ask the individual where they think they contracted COVID. See if you can't identify a common location across cases. Then you can go to those environments, those situations, and analyze them to see how they could be made safer. In that way, you accomplish two things. One, you can mitigate an ongoing outbreak. And two, you can, by identifying the environmental conditions or the social conditions that are occurring, that are giving rise to transmission, you can go to other similar environments and also modify those before their outbreaks, right? So what this would mean is that you would, and this is what Japan did quite well, along with South Korea and others, was that basically they set up a situation where they were putting out brush fires. They were able to smother these brush fires as they were occurring, but they were also able to kind of wet the ground, if you will, around the brush fire so they could prevent future outbreaks in the same or similar locations. And the key point here is that this was the pathway to equity. It was like, you will very quickly be led to the populations that are being most exposed. And invariably, those are going to be the populations that are the most marginalized in your communities. And we've seen that all around the world. And in fact, Dr. Oshitani's, the numbers would bear out. I don't know if everyone in this audience is aware, but within the first 12 months of the epidemic, between the time when the virus was identified and before we had a medical countermeasure that worked, a vaccine, about 30% of the United States population was infected. Like 30%. And that's probably low. Within 23 months, an estimated 50% of the population was infected. In Japan, that number was 9%. In South Korea, that number was 3%. So by using this strategy, they couldn't stop every case, but they were able to keep things under control enough for when they could get a medical countermeasure vaccine that would offer more blanket protections. KJ made a funny comment when he heard this, which is, he said, it's so funny you say this because when we're training our case investigators, they say, gosh, we were just on the phone so long with them with each case, because they just want to talk about where they think they got infected. And we keep telling the case investigators, stop that. Don't listen to that. Get on to the important part. But actually, that was the important part. They were, training their case investigators to throw out that critical piece of what I call public health intelligence. So KJ took this to heart, and he and his team moved heaven and earth to institute an outbreak investigation program in Massachusetts. And I just want to go through two examples, two outbreak investigations that took place in different circumstances. So you can start to see what KJ was up against when he started to try to institute this program. Do I go ahead and advance? Vanessa? Okay, so this is an outbreak investigation in Ireland. The Irish also really took on this retrospective contact tracing and outbreak investigation model. And it was early in the days of COVID. In fact, it was their first case in Ireland, was noted to be in a meat packing plant. And very soon after, another case was discovered there. Public health authorities immediately were alerted that these cases had occurred. And just because they had two cases, they declared an outbreak. They said 2 cases in the same place, it constitutes an outbreak. And over the next 5 weeks, 111 workers were infected asymptomatically. I think there were several deaths, but even from the beginning, within the first 2 weeks, when the authorities heard about it, they assembled a multidisciplinary team of researchers, academics, environmental health folks, veterinarians, animal welfare workers, huge team that went into the meat packing plant, and with testing kits and access to the state laboratory to run the testing kits, and they tested the entire workforce of this meat packing plant. They identified all the asymptomatic cases. For folks who were symptomatic, they immediately referred them to medical care locally. And they interviewed the cases, and they did a fairly extensive investigation of the air quality of the plant. And what they found, and they did this all over the course of about 3 to 5 days. And what they found was that most of the cases were linked with one specific room in the plant. It was called the boning hall. And it was a cramped space. It was very cold. It was dry air, and it had very poor ventilation. And so they started to implement measures that were really targeted, yes, to everybody wearing masks, et cetera, but really targeted at the boning hall, where they would installed fairly cheap air filtration devices, and made it so people were especially protected in that room, and they avoided closing down the plant. And so all of the workers kept their jobs, and there were no further infections for the 198 days following their institution of those measures. So as I like to say, the solution is it was COVID in the boning hall through the air. Okay, so next slide. Okay, so as KJ was starting up the outbreak investigation program in Massachusetts, he got a call from a public health nurse who was the only person who was in the public health board of a small Massachusetts fishing town, where the main industry was a fish packing plant. And she was distressed because she learned that from the head of the, well, actually she had probably became aware of it because of the publication of and some of the data that was coming out about the risks that meat packing plants posed and fish packing plants. But she became aware of 3 deaths that had occurred in workers working at a fish packing plant in her community. And she contacted the head of the business, and they said, oh my gosh, we're scared to talk to you. We don't want to have to close, but yes, we have had, these deaths of our workers. It's been devastating. The community is in uproar. We don't know what to do. But, this is the livelihood for this town, and, we're not sure how to proceed. She said, okay, well, I'm going to try to, conduct an investigation to see, if we can't make a different recommendation than a total shutdown. But she ran into immediately difficulties. Number one, she was the only person working for her local board of health. In fact, before COVID, she was only working there a half day a week. Okay, so she then struggled to get testing kits, which she was told by State Department, well, hey, we really are trying to conserve testing kits and make them available to the general public. We're not really giving them out to local investigators to go out into the field and test people. And she said, well, she begged and pleaded. She got the testing kits, and she goes out by herself to the plant, tests people who approach her, and then sends off the testing kits and does not receive the results. And she said, well, we contracted with Quest Diagnostics, and they're not getting the results back. And at the time, we were kind of surprised because, Quest had also, Brigham and Mass General also had contracted with Quest, and we were getting results back, within a couple of days. And so she said, no, I'm not getting the results back, and I don't know how to pursue the matter further. Furthermore, when I try to refer people to care who I'm finding are early in their disease course, I'm being told by the hospital that these individuals are not in their care network. And so they are not eligible to receive doses of monoclonal antibody that were given to the hospital. And she said, well, they did end up in their care network when they presented to their ER, in respiratory distress. And she, in the end, sort of threw up her hands and said, okay, we're going to have to close the plant. So I don't know ultimately if they agreed to go along with that, but it was a very significant issue. So, okay, so you compare Ireland to Massachusetts, right? You see an attempt to do this type of program in both places, and you immediately see that there are policy and structural challenges that KJ was contending with, which were significant. Can you go ahead and advance?
Yeah. Oh, nope. There you go.
Right. So, this sounded like a job for us, where we needed to identify the policy and systems challenges that needed to be overcome in order to implement an equity-centered approach to the COVID crisis. So we thought a good place to start with KJ would be to gather expertise and talk to practitioners who are also trying to stand up these programs across the country. KJ, it turned out, was not the only genius among us. So go ahead. Yeah. So we got a little bit of money from the MacArthur Foundation to start a project at PGPP that we called COVID Academy. And under the umbrella of COVID Academy, the first thing we started was what we called the Outbreak Roundtable, along with KJ. So KJ contacted other practitioners he knew and a wide array of jurisdictions across the country to join a roundtable, and every other week we would discuss outbreak investigations, the troubles that they were running into from a policy perspective, how they were overcoming those challenges, how they were structuring their programs, how they're administering them, what they were learning in terms of how COVID spread, and how they were learning to gauge whether their responses were effective. And we discussed all manner of things. I mean, it was very sweet. People would call and say, well, I'm not sure. How do you guys call a business? I'm scared. I don't know how to call a business, and have a conversation with them saying, oh gosh, we think your business is, sparking outbreaks. So, they would share very practical advice, but they also would start to share, some of the structural challenges they were facing and how they were overcoming them. And they started really reporting as we'd walk through it with them, and they started to present, week after week. They started to have some just incredible successes that they would share with us. I think, probably my favorite story is about comes from Louisiana, where they had a swingers conference in New Orleans, and it led to a huge outbreak of COVID, of course. And then the next year they were going to have the conference again. And so the head of the outbreak investigation unit there said, I'm going to call them, the conference organizers, and I'm going to see if I can talk to them about it. So he called them and they said, yeah, you know what, we'd love to work with you. Why don't you come and advise us on how we can have a swingers conference and make it so that we don't have an outbreak? And you know what, he did. And they didn't have an outbreak, which is incredible. I'm like, you guys should be like, win a Nobel Prize. Like, you can do that. anyway, so, really studying successes, and also, really talking about how they were engaging in new ways with their communities, winning over sports coaches, faith leaders, school principals, teachers, all manner of folks. They were able to go and engage with them directly and say, hey, listen, there is an outbreak. We need to understand how it is progressing, what we can do to stop it, and what we can do to protect you and make sure it doesn't happen again, with minimal interruption to your life as much as we can, right? And so they also started to share critical intelligence. And as we were listening to this, it would sometimes take us by tremendous surprise. One individual, for example, back in May of 2021, was presenting an outbreak that involved a vaccinated individual sparking a highly lethal outbreak through a church retreat weekend. And as they were presenting it, I was like, I don't think that the CDC knows that people who are vaccinated can actually transmit the disease. At the time, that was the CDC was reassuring people that the vaccine, was meant that they would not be able to transmit. So that was months. And when I raised it, everyone's like, oh, of course, vaccinated people can transmit. We see it all the time in the community. That's not a surprise to us. Why would you even think to note it? I was like, well, because I don't think the CDC knows it, right? And sure enough, it would be a couple months later where KJ's team would participate in the outbreak investigation in Provincetown, definitively proving that, in fact, it was vaccinated individuals who were transmitting in those circumstances, and finally able to get the CDC's attention. But after actually that presentation, I decided we needed more folks in COVID Academy. And so we started a second group, which we called the Power Working Group. But basically it was policymakers from a variety of backgrounds, including the CDC, who would come and listen to the roundtable presentations. And then we would circle up afterwards and discuss what the presentations had to do with policy and structure of our public health systems. And that way we were able to start to engage leadership across different domains. And in particular, I found the folks we'd invited from the intelligence community to be particularly helpful because they had faced very similar challenges of when to escalate information and intelligence from the ground to higher up officials, in dealing with the fallout of 9/11. So they recognized a lot of similarities there and were able to give us some good advice. And meanwhile, we also had started working with the National Governors Association, which was very interested in having us put together some policy briefs about public health reform, how public health is structured, et cetera, in the country, and how they can tackle COVID responses more appropriately. So, through all of these three groups, we started to really understand a lot more about the structure of our public health systems in the country, and how they were governed, how they were financed, and why these outbreak investigation programs were coming into up against such enormous difficulties. And I would just say there are a couple of key themes that we learned a lot, but there's just a couple of key themes that I'm going to share with you. The first is that states are in charge of public health in this country, and states organize their public health systems very, very differently. So about 2/3 of states, for example, delegate legal responsibility to their localities. That's called home rule. So you have these local boards of health that are in charge of policy making. And then you have other states on the other extreme where everything is run out of the State Department of Health. There is no local board of health or local autonomy over health. So that has big implications for how you institute programs and what you can do, and who you need to convince and partner with. And it was that realization that made me see that a lot of the efforts that have been made to reform public health in the country have failed because they have not taken into consideration who it is that is the decision maker in those cases. There are no common standards around public health agency performance. So it was only about 10 years ago that there was an accreditation process for public health agencies, both at the state and local level. It's voluntary, and when COVID began, less than 3% of our local and state public health agencies were accredited. there is a very significant operational divide, well, and structural and financial and organizational divide between our public health systems and our medical care systems as well. That has major implications. So we started to sort of map out the policy challenges that we saw. And we did indeed publish this recently in a paper. Can you just advance, Vanessa? Where we tried to describe for our policy audience the implications of the divide between public health and our medical care, and when it came to mounting an effective COVID response and instituting this outbreak investigation and response model. Okay, next one. But that wasn't enough, right? So we really needed to generate some solutions. So we had some ideas about what the problems were, but now what was the solution? So we went back to the roundtable. I just have my eye on the clock, so I'm going to speed through a little bit of this. Went back to the roundtable and said, okay, you know, you guys have been presenting these outbreak investigations and your responses to them. Can we come up with a consensus around what the idealized model of this type of program is? What are the key elements, functional elements that it contains? And we together landed on this notion that we call Community Outbreak Investigation and Response, which for short we call it CWIRE, where we've concluded that, you know, the way forward here is for every locality in the country to have the capability to detect, investigate, report, and respond on emerging health crises. And we realized in our conversations with folks that actually we were always in this country a day late and a dollar short when it came to emerging health crises. We were always, you know, failing to recognize the obesity epidemic, the opioid epidemic, the fentanyl epidemic, the Black maternal mortality crisis. You could go on and on, where you're just seeing that it's actually locals who in some cases are the last to know. That something new and bad is happening in their communities. So the purpose of CWIRE is really to empower our local communities to be able to detect, investigate, report, respond. Okay, go ahead, next one. And so we got together to map out exactly what this model is, and also in partnership with our frontline practitioners, published this paper. Oh, sorry.
That moves very interestingly. Keep going.
So we published this paper. I'm very proud of it because, you know, the co-authors on this are practitioners that are not generally used to publishing in academic journals, but in particular, this academic journal, Health Affairs, is one that is really a policy journal, and a lot of folks in health policy will read. And so it's a nice way to help folks engage with policy. Go ahead, next one. Right. So, you know, again, I was talking about the emphasis of the last step, which I am going to speed through a little bit here. But, you know, it's okay to have a good idea and a good idea for what a equity-centered model of care could be. But you have to also think about how it's going to get implemented. What are the vehicles, policy vehicles or programmatic vehicles by which you could actually further and implement a program like this? And here, you know, we've done a lot of analysis of what are the federal reforms, state reforms, and Massachusetts specific reforms that we could link CWIRE implementation to. I'm not going to go into great detail. I can talk to you a little bit about it if you guys have questions. But at the federal level, there are two pieces of legislation. First, the Prevent Pandemics Act, which was already passed as part of the Inflation Reduction Act in December. But upcoming is the reauthorization of the Pandemics and All Hazards Preparedness Act, or PAPA, for those that like to use acronyms. And that is must-pass legislation that is up in the fall for reauthorization. That's where CDC gets reauthorized. That's where BARDA, ASPR, HHS, a lot of its authorities are being articulated. And that is really important for this community. If you care about health disparities in the United States and the structure of our public health system, you know, we've got to show up for that and contribute to that. So we've done a lot of work in meeting with policymakers and providing, responding to requests for information for PAPA. Next one. And then, as I said, a lot of issues, a lot of the reform efforts have failed because they haven't engaged state leadership. So we've now decided to launch COVID Academy 2.0. This is a learning collaborative that we are undertaking with the National Governors Association to be hosted at Harvard through PGPP. To support states work through their public health reform efforts, really looking at 4 key questions. How will they staff their public health so that their frontline workers can detect, investigate, report, respond? How will they fund the local public health so that it's quiet as possible? The data system reform issues need to involve ways that they can escalate, frontline workers can escalate concerns, especially around health equity and disparities. And then how are they going to share resources and data across state lines? So, the idea here is that we're going to have state delegations that the NGA will help us put together, that we are going to help them workshop their reform efforts in this regard. And then, we also are turning our gaze to our own backyard in Massachusetts. We're hoping that, we can be helpful in Massachusetts, and Massachusetts would sort of be a pilot state for COVID Academy 2.0. There is a big piece of legislation also coming up, which is called SAFI 2.0, that will achieve some really important, address some egregious disparities in how Massachusetts addresses and structures and pays for its public health services. However, there really is a need for the practitioner lens in that conversation because of the ways that our very complicated health sectors and systems have to work together. Practitioners are the ones that can actually see, how things can move together, how our medical research community, how our clinical care community, and our public health community can work together. So we're excited to help support those conversations. So just to summarize here, how I kind of view this work, or the image that comes to mind is kind of this, it's a domino effect, but it's like the little dominoes. You start with one practitioner who has an observation, and then do other practitioners have the same observation, same challenges? Yes. Okay. Well, what does that mean, for policy and for structures, et cetera? And you kind of work your way out to really addressing what, I thought, Paul Farmer always, would frequently talk about this notion of structural violence. And, the idea that violence and harms would come to people because of the way our laws, our systems, our health systems, our policies are structured. And, often I think when, I and my colleagues talk about confronting structural violence, we often use the kind of language of it needs, systems need to be dismantled, they need to be torn down or burned to the ground or, put on trial. And sometimes that's certainly appropriate response. But I would say in sort of doing this work, I really come to think of it as incredibly creative work that is done in community with solidarity, and it's very stimulating, very interesting. It definitely takes a lot of mental energy to think through these problems systematically, but it is one that really does lead to really joyful experience. And I was laughing, a lot of times I get asked, do you still see patients? And unfortunately I don't, because these things take a lot of time, but I do feel like I still treat patients, right? I believe that this is medicine, this is clinical care, because you are allowing people to have clinical services and actually be healthy and have the benefits of all of the fabulous clinicians that we work with. So I'll end it there.
So Margaret really outlined examples of the way that as we felt the domestic crisis happening on a number of different levels, there was ways to bring together the international experiences to inform our more proximal experience here, and to very much think about how we can, getting a bit of echo, sorry about that, think about opportunities to respond for equity. And I'd like to give an example of how through some international work we are also broaching a lot of this and thinking through these same terms. So when you think about a problem or what the systemic driver of needing a response is. One of the areas that I've worked in considerably has been in the healthcare workforce, and really the fact that there is a complete inequitable divide in the availability of the healthcare workforce globally. So we used to sort of project a shortage of 18 million healthcare workers by 2030. We've now reduced that to 10 million, but where those inequities happen are actually still pretty profoundly embedded in certain geographic areas around the world, one of which being sub-Saharan Africa, where 37 out of 54 countries that make up the continent are facing critical healthcare worker shortages that actually threaten their chances of not only achieving universal healthcare, but of seeing a negative sort of, seeing worse progress on mortality and seeing now sort of a turnaround in terms of some of our successes in disease management. And part of that is being driven by growing economic inequity in the world. Part of that is being driven by a pandemic that has devastated health systems even further. It is being driven by conflict that is now driving and increasing in certain places around the continent. And it's being driven by climate change, where climate change is expected to put at least another 150 million people in poverty over the next decade. And we're also looking at growing burdens of disease across maternal health issues, non-communicable disease, communicable disease, and pandemic outbreaks, and just general instability related to drought, climate, water, food insecurity, and all of these pieces. And so the need for health workforce is only going to increase. Just to give, part of the problem too is that places like sub-Saharan Africa actually suffer some of the greatest burdens of disease. So you have, for example, just look at the example of HIV, 75% of the global burden of HIV is on the continent of Africa. It has a quarter of the world's global burden of disease overall, but only 3% of the world's healthcare workforce with which to address that. It has only 1% of the world's healthcare expenditure through all of the aid, domestic financing, everything. There's almost no money to close these gaps for the scope and scale of the problem. And it turns out that just 7% of global health aid over the past 10 years has actually been invested in building out a health workforce. We've been great at managing disease silos. So we're going to focus on maternal mortality, we're going to focus on HIV, but we haven't thought holistically about the opportunity to build strong, resilient health systems in a way that when COVID hits, you can respond to COVID. But when it becomes Ebola, you can respond to Ebola. When it becomes cholera from a cyclone, that you already had cholera, and the cholera has now gotten worse because you had the longest lasting cyclone in human history come over a country twice. And the cholera gets much worse. You have the same ability, you can respond again. And so you can pivot, if you will. And that kind of investment has versatility, is the argument that we would like to make. So in practice, what this can look like is, at least for Seed Global Health, which was shared is a nonprofit in the same vein, the way there's sort of a lot of intersection with the work that we all do. Seed has connections to Mass General and to the work we're doing here. And what Seed has really done is it has partnered actually throughout the last 12 years with 7 countries in sub-Saharan Africa to train over 35,000 doctors, nurses, midwives, the skilled health professional level, to help create a continuum from the community health worker to be a referral base towards some of the most core areas of disease in maternal mortality, non-communicable disease, obstetrics and pediatrics, and family medicine, and emergency medicine and mental health. So looking at the core components of kind of universal health coverage. We currently work in Malawi, Uganda, Zambia, and Sierra Leone. What that footprint looks like is slightly different depending on the priorities and needs of the governments where we work. So we go to where the government invites us, and we work alongside them towards their sort of healthcare workforce priorities to meet the burdens of disease in their countries. And what that might look like is, in Uganda, they wanted to build out a national emergency medicine training program for emergency medicine caregivers because over half the deaths in the country were from a failure of emergency and triage services. The result of that has been helping to graduate the first ever emergency medicine doctors and nurses in the country that were on the front lines of responding to COVID. They were the ones running the main COVID units in the urban centers where COVID was being seen, that had been on the front lines of responding to Ebola. And when Ebola hit, and there was an outbreak of Ebola last year, we were one of the first calls by the government to help train an additional 4,000 healthcare workers in a ring, so that the districts that were most affected, we were actually training healthcare workers in the other districts as well as the districts were impacted, so that if people left, which they did, and showed up somewhere else, they could be identified, triaged, and managed appropriately. And with that focus on training coming from the government of a healthcare workforce that was ready to respond, the Ebola mortality rate was much lower than expected. And actually, the pandemic or the outbreak was contained much faster than I think folks had expected. And this was an outbreak of Ebola that did not have a vaccine available. So there's no vaccine option. This was going to get shut down through contact tracing, isolation, and aggressive care. So what this feels like on the ground, though, is on a proximal level to where our work is, we don't have enough healthcare workers. We see this all the time. You know, the wards for summary work will have 2 midwives that are able to work in a ward of 36 delivering mothers, and the ratios just aren't there. And this is something that is known globally, but how do you bring those two things together to solve that problem? So one of the things that we did is we started to engage in a series of conversations with stakeholders that were also trying to figure out, how do we solve the health crises that we're facing? And so as COVID was, globally happening, the African continent through the African Union stood up the COVID-19 Commission, which was basically a commission that would look at 4 different areas of the COVID response for the continent for sort of a post-COVID engagement. So as COVID started to get under control on the continent, and it didn't hit a lot of countries in Africa necessarily as badly as other parts of the world, with some small hotspot exceptions, there was a sense that, well, we need to be ready for pandemics and we need a different approach to preparedness. And we should we as an African Union should take this problem into our own hands and really help dictate what this future looks like. And they created sort of several pillars to the COVID Commission. It was chaired by President Ramaphosa of South Africa. And one was on vaccine manufacturing locally, one was on vaccine procurement and equity. One pillar was on workforce and the fact that recovery, and the key to the COVID recovery was going to be actually building a fit for purpose workforce for the African continent that could meet the health burdens of the continent, and went everything from formally recognized community health workers to the specialists that are needed so that people aren't trying to leave to go elsewhere, and or to create regional hubs of cardiac surgeons, or in ways that the health needs of the continent could actually get met. So SEED ended up engaging in a series of conversations with the head of the Africa CDC, with the COVID-19 Commission, and really, what happened is that the Africa CDC announced something called the new public health order, which really broke out core pillars of areas that the African continent's public health approach would build out towards. And it was everything, again, from local manufacturing of medical countermeasures to epidemiology, surveillance, and data systems, and workforce was one of the top priorities of the new public health order, and to have that fit for purpose workforce that could meet the health burdens of the continent. So I'm going to skip ahead for a second. So what ended up happening was that through these early conversations, there was a convening of stakeholders that took place in November of 2021. Where basically we brought together folks from all different backgrounds, gender, measurement, community health workforce, the doctors, nurses, midwives, country governments, the Africa CDC, the African Union, the US government, the EU, multilaterals, foundations. And we brought folks together who've been thinking about health on the continent for a problem. And we did a stakeholder session on what would it take to build a fit for purpose workforce for the African continent in the right way. And what ended up happening was a group got formed of a task team that led to weekly meetings to really begin to carry this forward. A report was written and given to the COVID-19 Commission and President Ramaphosa, which was presented at the 35th Assembly of the Heads of State in February of 2022 for the African Union. And the African Union heads of state created a mandate that there would stand up a health workforce task team by the Africa CDC that would create a compact by which the roadmap for training the workforce for individual countries would be established. There would be a fund that would get set up that would allow for funding of this work, and that there would be the ability to actually create a pathway for training a fit for purpose workforce for countries that signed on, have the political will, in a compact system with accountability, with measurement, with metrics, that would be led by the Africa CDC and mandated by the African Union. This led to a series of convenings and additional stakeholder engagements. We presented the idea at the School World Forum. to launch it. We were at the World Health Assembly, where we had a meeting with multiple ministers from different African countries to solicit their feedback, their response. We've presented this to the private sector and to governments at Davos to really raise the need for this to be a multi-sectoral kind of draw and initiative. It was presented at the Africa Health ExCon in Egypt in June. There was a mid-year meeting with President Ramaphosa and the entire COVID Commission, where we talked about the progress, and we actually brought the funding forth to stand up the task team. This was socialized at the UN General Assembly with a high-level meeting that the African Union hosted to bring together these same stakeholders to talk about what this could look like, and then bringing it forward even into the climate discussions about the need for a workforce to actually be able to meet the rising burdens of disease that are going to arise from climate change, and that this is going to be part of the climate resilience and adaptation conversation that has to go forward. So what the proposed compact looked like, that was based off of the discussions with all the stakeholders, was effectively a centrally administered African-led compact to provide a framework, targets, metrics, and to scale up the workforce, so that if a country wanted to sign up for this, they basically would agree. The political statement would be, we want to be a part of the compact. There would be a needs assessment of the existing workforce, a needs assessment of the burdens of disease in the country and the anticipated disease burdens, a mapping of the kind of training and workforce needed to meet those diseases. And it would be everything from doctors, nurses, midwives, community health workers, epidemiologists, lab techs, radiology, manufacturing capacity, really defining a broad definition, health information systems, and governance and capacity at the government level. There would be facilitation and mobilization of a centrally managed fund at the Africa CDC. As the blueprints came forth and the costing of that blueprint was built out, the country could then access funding from the Africa CDC's fund to predictably and sustainably help fund this health workforce. So it's a little bit like doing HRH Rwanda at a larger scale across the continent for the countries that opt in. And that part of this would be building the domestic capacity and a 15 to 20-year timeline for all this, for the governments to build a roadmap to domestic sustainable financing themselves that could be worked on with economists, with the World Bank, with lenders, to understand how to sustain these salaries, to build out the anticipated health gains from populations that could lead to a tax base that can create the insurance plans and the financing long term. This also has the goal of harmonizing all the different partners and those working around a centralized plan, so that it's conquered and divided and really, but working towards a common vision that is government owned and bespoke to the country's needs. Again, the real key was changing timelines. And it's been fascinating talking to funders and others when we say, look, you've got to put the capacity to build this, and this is what it's going to look like. And they say, how long is that going to take? And we say a decade. You're going to need to embed somebody for a decade to build this capacity in a way that is sustainable. And nobody thinks in those terms, but we have to, or we're just going to constantly be plugging holes in the dam. And the goal is to really create an unprecedented accountability and impact through an alignment of vision, resources, and dedicated measurement, which I will come to. This would all be guided by a secretariat at the Africa CDC with partners. So the goal, though, is to measure this also from the beginning, and not just to measure, because what we measure is what we will do and where we will hold ourselves accountable. And the opportunity is not just to measure across multiple sectors. We want to measure not just the numbers trained and the numbers retained on the continent. We want to measure the health outcomes and how responsive the systems are to pandemics and outbreaks. We want to measure job creation on a continent where over half the population is under the age of 25. We want to measure gender parity. How many women get jobs? Are they paid the same? Are they paid at all? What does that look like for the communities? And how do we measure the economic benefit and the social benefit? So that hopefully, if we are audacious enough, we start to actually change the value system of what gets invested in and what is seen as a return on investment for this to some degree. And so that we can help really define health and the workforce that makes up the health system that delivers it as part of a global public good that is just necessary. This is also very critical in starting to really take shape in the climate and health discussions. And so, just to give another perspective, and I know a lot of our colleagues work in Malawi here as well, or Madagascar, Mozambique, and other places in Southern Africa, but this is Cyclone Freddy. Cyclone Freddy is the largest and longest cyclone to basically have sort of existed in human history. It passed over Southern Africa twice. It came over the lower part of the continent, went back out to the Indian Ocean, gathered steam, and came back in again. There was already, for example, in Malawi, I'm using this as an example of how disease gets manifest by climate change to some degree. There was already an incredible amount of environmental instability, waterborne diseases, outbreaks. There's already incredible fragility in terms of maternal outcomes, food instability, and a whole host of disease challenges there. And there's been a cholera outbreak for a year now, to the point that it's been so disruptive that schools had to close in January. Thousands have died and been infected, and it's been incredibly difficult to manage in the country. And the cyclone has only accelerated what that cholera outbreak can look like. And so we see very real impacts of how climate change is driving increased disease burdens. And in some places, it's extreme heat and kidney failure, or just death. In other places, it's preterm birth. But there's very real impacts of how climate change is impacting our health. The understanding of this nexus is only growing, and there's a lot of different stakeholders now coming into the space to think about what we need to do. The majority of the conversations have been around the mitigation of the health sector to contributing to greenhouse gases, and that's been primarily around the amount of energy, plastics, and consumables. But there's a whole opportunity to redefine this, if we're smart again, to build out a whole pathway for UHC and prevention. Because it turns out a diabetic adds a lot more CO2 into the environment than if you are not diabetic. So we, in our illness, actually are contributors to climate change as well, let alone just the suffering and the complete instability that happens as people are sick and not able to participate in labor, to care for their families, or to have the opportunity. And so this has to be thought about, I think, in a very holistic opportunity. There's growing number of attention being brought to this at the WHO's World Health Assembly this year. There's going to be a series of very high-level strategic dialogues on climate and health. There's a huge number of convenings, and the UAE, which is hosting COP28, is going to be doing a series of sessions, actually. And they just announced very publicly today that they are going to have an entire day dedicated to the intersection of climate and health for the first time ever in the Conference of the Parties. This will be a dedicated day and champion to really look at this nexus and to understand it. The task now, though, is to build out the evidence of how this is really looking on the ground, to take that evidence to inform the financing, the policy, the advocacy, the shifts and the changes, and to be able to really build out actually the opportunity to not approach climate change response in the same siloed, just do energy, just do jam CO2 into ground to mitigate the amounts, just make sure your medicines aren't stored at ground level where it floods, but at a higher level. But to think holistically about what a health-centered investment in climate response could look like and what that benefit is. That opportunity is completely on the table, but we need the evidence. We need to build again that group of unlikely stakeholders, which is finally starting to take shape. And we need to be able to drive this conversation into a responsible direction for our overall sustainability and well-being. And that is something else that we're going to be venturing into as we go forward. So those are, I want to leave some time for questions. So that's really, I think, where that's sort of the overview of what the domestic and the, and sort of some of the international opportunity is that illustrates the cascade that we're trying to operate around, which is really being very intentional and responsive to what is happening in that proximal location, and using it to drive that systemic, ingrained policy shift that can ensure that the entire environment is protective, different, and on the right path. Thank you.
I want to thank Margaret and Vanessa for that wonderful talk, and really fascinating and inspiring the levels that you're working at, and as you said, the intentionality with which you're working at those various levels and seeing how they do connect and how to make them durable. So maybe that's where the word institutional came from at the beginning, but really fascinating. For folks who are still around, I know we're going to go till 1:30. Any questions you might have, feel free to send them through the Q&A. So early on in the talk, you mentioned unlikely allies, and some of these even being industry. And can you tell us a little bit more about some of those unlikely allies?
Margaret, do you want to do MXM? I think this is like the best example.
Well, the one, I don't know if you're thinking of the same one, but I put up the kind of 4 portfolios that we that we work on, and one of them is on medical countermeasure R&D reform. So we can all imagine the problems that we've had in developing and distributing equitably the COVID vaccines. But back in the summer of 2020, right after Operation Warp Speed was announced, we delved fearlessly into that space and decided the best thing to do would be to put together a working group that would have representatives of vaccine developers from pharmaceutical companies, including Pfizer and Moderna, and as well as really the leaders of activist organizations dedicated to this issue of health equity, who had often been at war with the pharmaceutical companies and their rules. So we had a working group, and we thought that the best time to do it was before we knew the outcome of Operation Warp Speed, when everyone was behind a veil of ignorance. We weren't sure which candidates were going to move forward. It was also a time when the advanced purchase agreements were being signed behind closed doors. To this day, we do not understand what those advanced purchase agreements, those were the agreements between governments and the pharmaceutical companies were regarding how much vaccine they would purchase. Anyway, so we were all behind the veil of ignorance. Some pharmaceutical companies were losing out. Some feared they would. Some thought they were ahead, blah, blah, blah. Anyway, we gathered together to really ask ourselves, what is this the process that's correct? Is this how we want the world to work? Where we have an R&D process where gobs of money is being spent after the start of a crisis, and we have very little understanding of whether people are going to be protected by whatever is produced. So that led to a tremendously explosive set of conversations. We talk about, everyone was pretty well behaved, but it was very difficult to come to consensus because there was just a lot of there were some really hard disagreements, right? But actually, and there were honest disagreements. I mean, I think the benefit of doing it that way was that we started to see that it wasn't that people were evil. It's just that there were incentives aligned very strongly in different ways. So that came to a head when we said, okay, we're going to go and we're going to write a consensus report. We are going to write it. So Vanessa and I wrote it with Kendall Hoyt and our other allies. And then when we submitted it to the task force members, there was just a lot of pushback, a lot of sly responses saying, I'm not going to sign off on this unless you include this language. And then somebody else saying, no, that's so they can go before Congress and argue for this and this. Anyway, so it was a tough one, but actually we came through it really, really, really happy with the proposal on the table. And I think everybody came away feeling very positive about it. And that has been another big part of our work has been trying to get buy-in for and have the reform efforts reflect some of the things that we put in that report. But anyway, that was what comes to mind. Is that what you were thinking, Vanessa? Yeah.
Great. Again, if other folks have other questions related to that or other aspects, please let me know. Margaret, you mentioned a lot of these questions are triggered initially by the observations of health practitioners on the ground. And how is that itself formalized? I mean, KJ is brilliant, and he's one person, but in general, is there a mechanism for you to decide which problem surfaces to you next among the vast array of practitioners of various professions?
Yeah, I think we would, as we build this out, we would really like a more formal relationship actually with the department. So you're giving me the perfect plug, where we really do see that this is this process of helping practitioners who are especially involved in delivering health care in very fraught environments as a necessary component of their work. And so, we were sort of modeling that with Partners in Health during their contact tracing program. So, I guess, if I had my way with the world, we'd really like to offer it as kind of a standing service, right, to any practitioner in the Harvard Medical School community, where we can, if they identify problems they want to bring to us, we can, have a systematic approach to helping support them. And that it's happening very much ad hoc right now. So, for example, I don't know if you've been following the disaster in Haiti, and Haiti is really, I mean, in governmental freefall. And a lot of the, healthcare organizations, of course, ours included, are very concerned about maintaining, keeping their doors open. And so just, before this meeting, people are calling me saying, oh, how can we broker a conversation with some of the security foreign policy makers in DC, because we think we need to discuss what options are. So a lot of the projects have come about organically because of that relationship, but we would like it to be a more formal sort of intake process.
I think that there's a big opportunity for this model to be replicated to any problem. And I think to really help think through and analyze where there's an opportunity, because we spend so much time and effort and really building out these very strong solutions. And Harvard Medical School has an unprecedented number of practitioners across all definitions that are doing this outstanding work. The question becomes, how do we codify that and use that incredible evidence and information to really systemically help shift and adjust, accompany these policies into the right place so that all that effort that we're putting in on the ground becomes enduring. And there's different challenges. Haiti is a real extreme of how you might be able to do that. But there are a lot of levers that can get pulled here in the US or among different communities, 54 countries in the African Union all agreed to train a workforce. It's a question of bringing the evidence and what that return on investment can look like and why it matters and the how, and to be able to kind of accompany through that troubleshooting. But then that makes all of our work easier if we're suddenly money available to do the stuff we're doing anyway, and there's policies that are going to retain and support. And so I think that's really the opportunity.
And often we're asked, why the medical school? Why are we here at the medical school, right? I mean, why not, School of Public Health, which is great. I have a lot of colleagues there and fantastic. Also, I have an appointment at the Kennedy School, which is exclusively devoted to policy. There's, a thought that, you're better if you are, addressing policy issues over on the side. The reason we have been so insistent that we stay at Harvard Medical School in the Department of Global Health and Social Medicine is because of its proximity to the practitioner. And, we've seen over and over again, right? Policy that is written without the practitioner perspective is ones that tend to, and maybe this is a good way to study this and really measure outcomes. But I would bet my hypothesis is that when you don't take into consideration practitioner perspectives, you have policies that are more inequitable, that drive disparities more, because policymakers can't see. They're just making policy in the blind. They can't understand how these things are going to play out on the ground. That versus other drivers of inequities, which are certainly, the greed and selfishness and, racism or whatever, that does exist. I'm not saying it doesn't, but a lot of the problems that we see play out are often, crimes of omission rather than commission, right?
Yeah, we're already vectors of information on the ground for sure. You're working at multiple levels. And theorizing at multiple levels. And it seems in various conditions seem to offer their own answers for which levels are most relevant to preventing change, right? From the local level to the state level, national level, the regional level. How do you allocate your own resources in your program about where you should be conducting your activities, whom you should be convening, given the magnitude and the heterogeneity of the conditions and the possible responses?
We could probably be a little better about that. Yeah. So this,
it's a hard. I'm gonna answer.
Okay. Well, I guess my only 2 cents is, I do think that we do a lot of thinking about who are the decision makers and who are the influencers. And, I do think, like, if you look at COVID, all these blue ribbon panels, which are fabulous, a lot of them come out with reports really focused on what's going to change at the federal level. And I keep trying to say, even if you implement all of those CDC reforms, HHS reform, even if you do that faithfully and they're great, you're not going to make the change on the ground that you want to see, because the states is really where the decisions have to be made. So, and that's a tough nut to crack, right? Because they're like, well, there are 50 states. How are we going to do that? So that's why I'm so glad, right, that we're at Harvard, because Harvard has the convening power of, the super magnet. I mean, it's, very easy to try to set up forums where lots of people want to participate across the states. Anyway, so that's my two cents. Vanessa, sorry, what were you gonna say?
No, I also was just going to add that, I mean, some of it also is really trying to just, it is looking at where there are levers to be influenced. And I think that trying to be opportunistic to those moments and spaces. Part of it too is trying to, is to, I think, be creative about ways that some of the times you have to be creative, like, because I think that a lot of folks don't understand the impact of policy. And so we also are, sometimes helping people. There's a lot of effort to kind of raise the resources and connect people to understand where there's opportunity to actually be in delivery. But
Great.
Yeah.
Well, this is, oh, sorry, go, Margaret, keep going, please.
Well, I was going to say one of the funniest things I find is, and one of the most enjoyable in some sense about being also again at Harvard Medical School, is that a lot of the practitioners I'm finding are intimidated, right, about talking to policymakers. They don't feel comfortable sharing their experience, often because they don't actually totally get how their experience is related to policy. So, sometimes all folks need, like, with Haiti, I'm not going to be involved in that really. I'm just kind of trying to connect people so that they have the confidence to say, like, hey, this is a problem and I want to talk about it with you and what the solutions are. And the funniest story I have in that regard, if we have time for one quick story, is again, another one of our portfolios is on threatened health systems and a health system disruption from armed conflict. And so we did this work with one of my students did this work for the NATO medical command. So every military in NATO has a surgeon general, and they all sit on one command where they try to figure out how they're going to care for their soldiers should they be involved in combat. And the student pointed out to them that if they're considering conflict with Russia, which unfortunately they are, they really do need to think about their civilian ministries of health and their civilian health systems, because in most European countries, their civilian health system actually provides most of the care for their military. And the surgeon generals were so cute. They were just like, but wait, we are basically scared to talk to our civilian ministries of health. We don't want to get involved in their business. They're going to be upset, and it was like, it was very sweet that the student from the Kennedy School was saying, no, you're important. You need to go talk to them. A lot of it is, connecting people and different across silos, and Harvard the Harvard brand sort of has this magical quality to it where you're sort of able to give people the confidence, that they should engage one another. Right.
Have you been invited or to speak at all regarding areas of my own personal interest around antimicrobial resistance and global policy or federal policy regarding approaches to antimicrobial resistance? Or that I'm not looking at anything more to your portfolio, which is amazing.
Another problem we have to worry about, Scott. Sorry. Did you say COVID resistance?
No, sorry, antimicrobial, like antibiotic resistance.
Yeah. So yeah. Okay. So there is yes. So that world of antimicrobial resistance has, because of COVID in some sense, and because of sort of the global health security world, which really grew after Ebola, West Africa. There was the Global Health Security Initiative. And anyway, they sort of took up this notion of, the threat posed by antimicrobial resistance. One of the big funders of that work is the Wellcome Trust, very interested in antimicrobial resistance. But I would say that has sits in a funny place that makes it a little difficult to access, because it's between medicine and health security, but also environmental management and agriculture and food, animal, livestock kind of world. And so some of the policymakers are in very different places and trying to tackle it from kind of weird angles. I have high hopes that actually the climate and health discussion will start to provide a forum for policymakers from different angles, the kind of One Health approach, that will start to make its way into the climate discussions and climate and health discussions, and we'll be able to tackle that a little bit more head on. I would say that the Wellcome Trust folks have done a lot, and there are folks that are pushing forward on key reforms in that area that I'm not as up to speed as I should be, but it is definitely, it's in there. It's in the mix. Is that a particular interest of yours, Scott?
It is absolutely, and you can see a lot of shared characteristics around access versus excess and equity, and the roles of industry versus various arms of public health and agriculture and the environment. So another large problem requiring really innovative, creative solutions and a lot of stakeholders.
Well, we look forward to working with you, Scott.
Fair enough. Well, this was great. I mean, super inspiring what you're doing and how thoughtful you are in modeling all this, and amazing in convening all these various stakeholders. So thank you very much. Really grateful. And for folks who are here, let people know this is going to be on video as well. So people who couldn't come today can certainly watch this. Folks who are following the series, we'll be meeting again on May 24th. We'll have the first of what will be a number of series devoted to global palliative care. So for Dr. Bourdeaux and Dr. Kerry, thank you so much. This is really wonderful.
Thank you for having us. Thanks for joining.